Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today in this lesson, let us talk about the decorticate and decerebrate decorticate. These posturings indicates severe brain damage, either due to road traffic accidents or due to metabolic or infectious causes involving the brain tissue. The lesions could be either below the red nucleus or above the red nucleus. The lesions below the red nucleus are supposed to result in the decerebrate posturing, and the lesions above the red nucleus are supposed to result in decorticate posturing. These postures are characterized by stereotyped movements to noxious stimuli in an unconscious patient. Okay, patient is unconscious. When you give a painful stimulus to these patients, they suddenly go into these serious type of movements of the entire body. Okay, either flexion or extension. This picture shows the patient in the decorticate posturing and the patient in decerebrate posturing. Decorticate posture is characterized by the flexion of the upper limbs at the elbow, adduction and internal rotation at the shoulders, and flexion at the wrist and the flexion of the fingers. With regard to the lower limbs, they are extended both in decorticate as well as the decerebrate postures. They are extended at the knee, adducted at the hip with internal rotation, and plantar flexion of the foot with pointing down of the toes. These are abnormal responses to noxious stimuli, characterized by stereotyped movements of the limbs and the trunk, as I told you earlier. They were first described by Nobel Charles Sherrington in 1898. They are bilateral and symmetrical. Sometimes they could be unilateral or asymmetrical, especially when the lesion is of less severity. That means when the brain injury is of less severity, these movements could be unilateral or sometimes asymmetrical, okay? Or sometimes they could be inconsistent. Because these abnormal postures indicates diffuse brain injury, they're not giving you any diagnosis. So etiology has to be found, is identified in order to make the plan to the effective treatment. So it requires early diagnosis and effective treatment in order to reduce the morbidity and mortality. Once the students encounter this particular posturing in a patient admitted into the emergency, it is almost very important to identify the cause of this particular posture in order to treat them effectively and avoid the sequelae and mortality. The prevalence has not been well reported with regard to these particular abnormal postures. Coming to the decerebrate posture and its features, the patients will be unconscious. In decerebrate posture, as you have seen the picture, all the limbs are extended. Lower limbs are extended at the knee, adducted at the hip and internally rotated, There is a dorsiflexion of the foot with pointing out of the fingers downwards. The upper limbs are also extended with extension at the elbow, pronation, okay, at the pronation of the forearm, flexion of the wrist and the flexion of the fingers. And the upper limbs are adducted and internally rotated at the shoulder. Okay. That is said, decerebrate posture is due to the lesion below the red nucleus. So this picture shows the patient in decerebrate posture. There see all the limbs are extended. There is upper limbs, especially the lower limbs in both the postures, they are extended, same feature. Whereas in decerebrate posture, there is extension of the upper limbs also. That is different from the decorticate posture, wherein upper limbs are flexed. In decerebrate posture, it is upper limbs are extended along with the lower limbs. And the etiology could be the lesions in the supratentorial lesions or infratentorial lesions, or the lesions could be diffuse. The supratentorial lesions, they could be abscesses, hematomas, hemorrhages, whereas traumatic brain injuries with intracranial hemorrhage associated with raised intracranial tension, and also the tumors could be the cause in the supratentorial lesions. Coming to the infratentorial, again there could be abscesses, there could be tumors, infarcts of the brainstem or diencephalon. Okay, intracranial hemorrhages into the cerebellum or into the midbrain. There could be traumatic brain injury. So there could be hydrocephalus, again results in the compression over the brainstem, thereby resulting in the features of decerebrate rigidity. So any lesion below the red nucleus is going to result in decerebrate rigidity. There could be diffuse or metabolic causes. So like cerebral malaria, encephalitis, erectile disturbances, lead poisoning, hepatic encephalopathy, hypoxic ischemic encephalopathy are some of the causes to explain decerebrate rigidity. Well, sometimes the lesion could be somewhere in the midbrain, that is, diencephalon, initially presenting as the corticate rigidity or with abnormal tone, etc., and slowly progresses to the corticate rigidity. Then, as the lesion progresses downwards into the brainstem, it results in the decerebrate rigidity. Once the lesion progresses down to the medulla, it results in the hypotonicity. Okay, ultimately resulting in the cardiorespiratory arrest and death. These postures could be there in the patients with brain death in brain death patients. Coming to the decorticate posture. Again, it's again hypertonic posture. Okay. The lower limbs are as they were in the decerebrate posture, with the extension of the knees, okay, adduction and internal rotation of the hips, and the plantar flexion of the foot with the pointing down of the toes. Okay. Whereas in the upper limbs, they are flexed at the elbow, arms pronated and folded onto the chest. Wrist is flexed and shoulders are directed with internal rotation. So with regard to the difference between the decerebrate posture and decorticate posture is the upper limbs are extended in the decerebrate posture, whereas in decorticate posture they are flexed at the elbow and adducted and internally rotated at the shoulders. Okay. Sometimes these postures could be incomplete, sometimes inconsistent, or they could be asymmetrical. Need not be symmetrical with bilateral involvement. When the injury is of less severity, it could be inconsistent or asymmetrical. In decorticate rigidity, the lesion is above the level of the red nucleus. So red nucleus is level of the red nucleus is considered as a plane to divide these two types of postures. Well, when there is a sensory stimulus, when you give the patient a painful stimulus and noxious stimulus, there is these are carried along the afferents to these spinothalamic pathways, and they reach the cortex, and the command is sent from the cortex down to the lower centers via the brainstem cerebellum and to the lower centers. There is a to and fro circuits between the lower centers and the cerebral cortex, ultimately resulting in the abnormal movements. So, in these patients, laboratory evaluation is very important, should be carried out as early as possible. And not to waste the time, ask for the MRI scan of the brain in order to identify the level of lesion and type of injury. Okay. This is the MRI picture of the patients with this decerebrate and decorticate posturing, showing the infarcts. In this picture, you see the red nucleus, the pons, and reticular formation, etc. The lesion here is the decerebrate rigidity is caused by the lesion somewhere below the red nucleus. Decorticate posturing is secondary to the lesion at the level above the red nucleus. Once diagnosis is confirmed, surgical evacuation of the central hematomas, treatment of the infections, correction of the metabolic errors, and in case of hydrocephalus, shunt surgeries have to be carried out as early as possible in order to avoid morbidity and mortality. Recovery is good. The patients presented with the hematomas, that is extradural hematomas, they do well following the surgical evacuation of these hematomas. And treatment of infections and correction of metabolic errors like hypoglycemia, the improvement is good. And shunt surgery should be done in the patients with hydrocephalus. And after recovery, the patient should be subjected to rehabilitation in order to improve the functionality of the functional capability of the patient in order to carry out the normal lifestyle. Well, the patients admitted with the traumatic brain injuries with decerebrate presentation, they carry 70 to 80% of the mortality. Okay. Whereas only 37% of the decorticate process and 60% of the decerebrate process they survive. Younger the age, the less severe the trauma, the early the treatment, better will be the survival rate. Coming to the hematomas, extradural hematomas, they do better than subdural hematomas. So this is all about the decerebrate and decorticate postures. And these are nothing but the stereotyped movements involving the trunk and the body to noxious stimulations. Indicate underlying diffuse brain injury. Okay. The cause of these particular postures have to be identified along with the history and the laboratory evaluation. Treated early, the morbidity and mortality can be reduced. And thank you very much for patient listening. And this is very important for the students to learn about these particular postures. When they encounter the patients in this particular abnormal postures, it's very important to go ahead with the identification of the cause and treat them effectively in order to reduce the mortality. Thank you once again. We'll meet you in the next class. Until that time, bye bye.